Good morning and welcome to the second day of your NRPh Plus online course. We are beginning our Module 5, which is on newborn resuscitation. The first activity in this module is a lecture on principles of newborn resuscitation. This lecture aims to provide knowledge in the principles of newborn resuscitation, the preparation required prior to delivery of the newborn, and some adjustments to make in the setting of COVID-19. At the end of this lecture, the participants are expected to understand the following: changes in physiology as the fetus transitions from in utero to extrauterine life, preparation for and the sequence of resuscitation in the newborn, and post-resuscitation debriefing. This year, we've added objectives to address neonatal resuscitation during the COVID-19 pandemic, including understanding potential clinical features in pregnant women, mother-to-infant transmission, and additional steps and maneuvers in the resuscitation of COVID-19 suspect or confirmed newborns. Which babies will require resuscitation? Most newly born babies are vigorous, and only about 10% will require some assistance, while only 1% will need extensive resuscitative measures to survive. Because of this, all newborns require an initial assessment to determine whether resuscitation is required. In the fetus, oxygen is transferred across the placenta and the lungs are not utilized. The alveoli are filled with lung fluid. In the normal transition, the following major changes take place within seconds after birth. First, the alveolar fluid is absorbed and air enters the lungs. Next, the blood vessels in the lung tissue relax, thereby increasing pulmonary blood flow. Next, the umbilical arteries and veins constrict, removing the low resistance placental circuit, which leads to increasing systemic blood pressure. What can go wrong during transition? A baby may encounter difficulty before labor, during labor, or after birth. Some of the problems that may disrupt normal transition include the baby may not breathe sufficiently to force fluid from the alveoli, or foreign material such as meconium may prevent air from entering the alveoli. Excessive blood loss may occur, or there may be inadequate cardiac contractility or bradycardia from hypoxia and ischemia. A lack of oxygen or ventilation of the newborn's lungs results in sustained constriction of the pulmonary arterioles, preventing arterial blood from becoming oxygenated. Prolonged lack of adequate perfusion and oxygenation to the baby's organs can lead to brain damage, damage to other organs, or death. As mentioned, all newborns require an initial assessment to determine whether resuscitation is required. This initial assessment is done while performing the initial steps of early essential newborn care. Remember, while we are doing the thorough drying, we are doing a quick assessment of the baby's breathing and tone. As part of our preparation, all rescuers should be in appropriate PPE, and personnel in the room should be limited to only those essential for patient care. Prior to the delivery, it is important to assess for perinatal risk by communicating with the mother and the obstetric healthcare provider. Most newborn resuscitations can be anticipated by identifying the presence of antepartum and interpartum risk factors associated with the need for newborn resuscitation. Once the risk factors are identified, we can provide antenatal counseling for the parents, give them information about the possible outcome and interventions that need to be done to facilitate effective transition for their baby. We assemble the appropriate personnel and conduct a team briefing. Remember that successful resuscitation will entail effective communication and teamwork. We must provide immediate access to supplies and equipment, and make sure to perform an equipment check prior to each delivery. We must ensure that the environment is safe for the newborn. Keep the room temperature between 25 to 28 degrees Celsius. Minimize drafts by turning off electric fans and air conditioners, and turn on the radiant warmer. As part of our risk assessment, it is now routine to screen for COVID-19 among mothers. These mothers are identified either through symptoms, as shown here in this slide, or through nasopharyngeal swab PCR for SARS-CoV-2. Currently, majority of maternal cases delivering at PGH are either asymptomatic or with mild symptoms. Mother-to-infant transmission of COVID-19 may occur intrauterine, intrapartum, or during the immediate postnatal period. With institution of proper measures, intrauterine and intrapartum transmission is described as very low or rare. Looking at our PGH experience, out of approximately 700 deliveries since March, only 3 neonates have tested positive for COVID-19, 2 of which were asymptomatic. This rate of transmission is lower than recent published data that suggests that approximately 2% of infants born to women who test positive for SARS-CoV-2 near the time of delivery have tested positive in the first 24 to 96 hours after birth. In terms of attendance to deliveries, the standard of care has not changed, and the AAP recommends that maternal COVID-19 alone is not an indication to call the specialist or neonatologist to attend to a delivery. COVID-19 safety precautions include proper PPE, limiting personnel inside the delivery room, procedures done by an expert provider, especially intubation. Since newborn resuscitation and subsequent care in the neonatal ICU involve procedures which are aerosol generating, this requires the use of PPE and isolation precautions to address airborne, droplet, and contact precautions. All pregnant women should wear a medical mask during delivery, and an established triage procedure should be performed prior to delivery, which includes a review of history of travel, occupation, contact and clustering, the presence of clinical features of COVID-19, and in PGH, a routine RT-PCR testing for SARS-CoV-2. Here are some of the identified risk factors that are associated not only to obstetric complications, but also for the need for newborn resuscitation. Some antepartum factors include prolonged rupture of membranes, that is, over 18 hours, hypertensive disorders and eclampsia, maternal infection, and multifetal pregnancies. Intrapartum factors include excessive maternal bleeding, malpresentation, abnormal fetal heart tones, prolapse or nuchal cord, rapid hard labor, foul-smelling amniotic fluid, prolonged labor, and shoulder dystocia. Remember that successful resuscitation entails effective communication and teamwork between appropriate personnel. Every delivery should be attended by at least one person whose only responsibility is the newborn and who is capable of initiating resuscitation. Rescue personnel should be available for emergency. Currently, we minimize the number of providers present at a delivery to reduce exposure and to minimize the use of PPE. There must be immediate access to appropriate supplies and equipment. This slide shows from the bottom right corner our stethoscope, and going counterclockwise, we have different sizes of endotracheal tube. Then we have a laryngeal mask airway, which we do not have readily available here in PGH. Topmost would be your stylet. Below that, your scissors and tape for securing the ET to the face. And below that, the suction tubing. Moving on to the left would be your appropriately sized neonatal self-inflating ambu bag and your laryngoscope with different sizes of blades. Below that, you have an airway and the meconium aspirator. And lastly, we have the CO2 detector and a manometer to monitor pressures given via the ambu bag. Additional equipment required when attending COVID-19 deliveries would of course be your PPE, bacterial and viral filters which we attach to the ambu bag, the acrylic box for intubation, disposable laryngoscope, and closed circuit systems. Once the appropriate personnel are assembled, a team briefing is encouraged to identify and assign specific roles for each team member. A closed-loop communication is important to ensure that tasks are being carried out appropriately. If with the luxury of time, especially for known high-risk cases, it is recommended to conduct multi-specialty conferences to plan resuscitation, conduct dry runs of resuscitation, and debriefing to improve skills prior to the actual delivery. Each setting must be ready and fully equipped to attend to COVID suspect or confirmed patients about to give birth. Ideally, every family should have the opportunity to have a discussion prior to delivery to establish a shared decision between the team and the parents as to the approach to resuscitation of the newborn if needed. Parents are considered as part of the team as they stand as surrogate decision makers for their own babies. If with adequate time, they must be given relevant and accurate information about the risk and benefits of every treatment option. This includes discussions with the family about the risk and benefits of co-location or temporary separation, designation of an area for newborn resuscitation within or outside the delivery room, rooming in, and breastfeeding. These options will be further discussed in the succeeding lecture. The newborn's best interest must be prioritized. Here we have a sample of a delivery room setup when attending to a confirmed or suspect COVID-19 mother. We have source containment by providing a medical mask to the mother with the obstetrician or obstetric healthcare provider also in appropriate PPE. It is suggested that a physical barrier or curtain is provided between the resuscitation area if performed in the same room with a distance of 2 meters away from the mother. The most experienced provider should be attending the delivery, with additional providers outside the room for minimal exposure. Airborne precautions for aerosol generating procedures such as intubation should be provided. Resuscitation is followed as per existing resuscitation guidelines. The next slide will show us how to perform an equipment check prior to delivery of the newborn.
The equipment check is a vital part of resuscitation readiness. All equipment for a complete resuscitation must be immediately accessible and fully operational. Simply noting which items are present does not help you determine which items are missing. Check your supplies in the order in which you will need them, starting with what is needed for initial steps and ending with equipment needed for complex resuscitation. Use the equipment checklist from the instructor manual. Can you warm and dry the newborn? Preheat the warmer and make sure there are towels or blankets for drying the newborn. Can you clear the airway if necessary? Check for 3 things in this category: a bulb syringe, a suction catheter attached to the wall suction set at continuous and adjusted to 80 to 100 millimeters mercury pressure, and the meconium aspirator in case tracheal suctioning is required. Can you auscultate the newborn's heart rate and breath sounds? Make sure the stethoscope is present and working. Next, check to make sure you can administer oxygen if necessary. Turn on the oxygen to 5 to 10 liters per minute. Adjust the oxygen blender to the initial concentration desired and make sure the tubing is connected to the oxygen source. When you think oxygen, think pulse oximetry. Have the probe ready to attach to the newborn first, then connect it to the oximeter. Can you ventilate the newborn? Check your positive pressure ventilation device to make sure it's functioning correctly. The self-inflating bag is tested by sealing it against the palm of your hand. Does the bag deliver a breath? And does the pop-off valve work? Do you have a term and preterm size mask? So far, you can warm, clear the airway if necessary, dry the newborn, auscultate, oxygenate, and ventilate. Next, check the intubation equipment. Check the laryngoscope for a bright light and secure bulb. ET tube sizes 2.5, 3.0, 3.5, and 4.0 should be available, along with stylets. Make sure you have an end-titled CO2 detector ready for use. Can you medicate the newborn? Make sure medications and supplies to place an emergency umbilical venous catheter are accessible in your crash cart or medication box. Your equipment check is complete. You can warm and dry, clear the airway 3 ways, auscultate, oxygenate, ventilate, intubate, and medicate. Your equipment check is complete and you're ready to receive the newborn.
The NRPh Plus algorithm begins with the birth of the baby. Each resuscitative step is shown in a block. Below each block is a decision point to help decide whether proceeding to the next step if needed. The first minute of life of a newborn is very critical. Within this time frame, it is essential for the team attending to the newborn to be able to quickly assess and decide whether resuscitation is required. As discussed during the EINC module, all newborns undergo thorough drying and a quick assessment immediately after birth. During this initial assessment, the newborn's respirations and tone are examined. If the newborn is apneic or gasping or limp, the initial steps of resuscitation must be delivered. These initial steps include 1. Calling for help from the rest of the team members who were previously identified as skilled in neonatal resuscitation. 2. Change the wet linen to dry to maintain thermoregulation. 3. Clamp and cut the cord. 4. Transfer the baby to the warmer for further temperature control. 5. Position the airway into a sniffing position. And 6. Clearing secretions from the mouth and then the nose, only if necessary. The newborn is then reassessed after performing these steps, and if still with persistence of apnea or gasping, positive pressure ventilation is initiated and the baby is hooked to a pulse oximeter for monitoring. Remember that the most important and effective action in neonatal resuscitation is to ventilate the baby's lungs. In those instances of mothers suspect or confirmed to have COVID-19, an area for possible resuscitation must be identified beforehand. Options for this area must be discussed with the parents prior to delivery and also depend on the available facility. One option is to conduct resuscitation in a completely separate room from the mother, preferably with negative pressure. Another option is to perform resuscitation within the delivery room, at least 2 meters away from the mother, with a physical barrier provided and with limited providers. The third option is to perform resuscitation still in the delivery room in an isolation room. Again, at least 2 meters away from the mother with limited providers. The compromised newborn may exhibit one or more of the following clinical findings: poor muscle tone, depression of respiratory drive due to insufficient oxygen reaching the brain, bradycardia, low blood pressure, tachypnea, cyanosis, as shown here in the diagram. Other conditions such as infection, hypoglycemia, or depressant drugs administered to the mother before birth may also cause these symptoms. When babies are deprived of oxygen in utero or after delivery, they undergo a well-defined sequence of events that begins with cessation of respiration. This is called primary apnea. When the fetus or newborn first becomes deprived of oxygen, an initial period of attempted rapid breathing is followed by primary apnea and a decrease in heart rate. An important point is that during primary apnea, the newborn will respond to tactile stimulation. If oxygen deprivation continues, deep gasping respirations develop, followed by secondary apnea. The heart rate continues to decrease and the blood pressure decreases. Another key point is that during secondary apnea, simulation will not restart the baby's breathing. Assisted ventilation must be provided to reverse the process triggered by oxygen deprivation. If a baby doesn't begin to breathe immediately after being stimulated by thorough drying, he or she is likely in secondary apnea and will require positive pressure ventilation. Note that all aerosol generating procedures, which includes positive pressure ventilation, must be performed with appropriate PPE. Most babies in secondary apnea will respond to effective ventilation with a rapid improvement in heart rate. The longer a newborn has been in secondary apnea, the longer it will take for spontaneous breathing to resume. If the heart rate does not improve rapidly with effective ventilation, Myocardial function may be compromised and chest compressions and/or medications may be required. Going back to our algorithm, once the initial steps of resuscitation are carried out, we then need to reassess the baby's condition. The subsequent decisions are based on the evaluation of respirations, heart rate, and color, or oxygen saturations. If the newborn is not breathing or is gasping or has a heart rate of less than 100 beats per minute, then ventilation corrective steps must be done in sequence and intubation is considered if needed. However, if the baby has spontaneous and adequate respirations with a heart rate of more than 100 beats per minute, but is observed to have labored breathing or cyanosis, the following maneuvers are performed. Position and clear the airway of the newborn. Initiate pulse oximetry, and provide supplemental oxygen as needed in persistent central cyanosis or failure to reach targeted preductal oxygen saturations as indicated in the table. Initiation of CPAP must also be considered, especially for preterm newborns with labored breathing. After providing effective ventilation for 30 seconds and the heart rate is noted to be less than 60 beats per minute, perform intubation of the newborn if not yet done previously, and initiate coordinated positive pressure ventilation and chest compressions. This is needed to maintain sufficient cardiac output so that blood can reach the lungs to pick up oxygen. Support circulation by starting chest compressions while continuing effective ventilation. After 30 seconds of chest compressions, evaluate the newborn again. Consider establishing an intravenous access via placement of an umbilical catheter. It is suggested to pause chest compressions during attempts to intubate as precautions in COVID-19. If the heart rate remains less than 60 beats per minute despite adequate and coordinated ventilation and chest compressions, administration of intravenous epinephrine is indicated. Give epinephrine as you continue assisted ventilation and chest compressions. Consider other possible causes of persistent bradycardia, such as hypovolemia or pneumothorax. If the heart rate remains less than 60 beats per minute, coordinated ventilation, chest compressions, and epinephrine administration are continued and repeated. In summary, the following are key points in newborn resuscitation. Effective communication and teamwork is key. The most important and effective action in newborn resuscitation is to ventilate the baby's lungs. Positive pressure ventilation must be provided within the first minute of life for infants in secondary apnea. If the heart rate does not increase with positive pressure ventilation, ventilation corrective steps and/or chest compressions and epinephrine may be necessary. If the heart rate remains less than 60 beats per minute despite effective ventilation, then additional steps are needed. If the heart rate improves to more than 60 beats per minute, then chest compressions may be discontinued. If the heart rate improves to more than 100 beats per minute and the neonate is breathing, then positive pressure ventilation can be discontinued. Keep in mind that if no improvement occurs after 30 seconds, proceed to the next step. Okay, so now we come to this last very busy slide, which covers key points regarding COVID 19. So, allow me to just highlight some interventions or changes we have instituted here in our setting at PGH. Number one, it's important to determine status of the mother, whether COVID-19 positive or suspect. So for those who are confirmed COVID-19 or suspect due to symptoms or unscreened, these mothers are delivered at the third floor operating room or, if in imminent delivery, at the Ward 15 delivery room. The newborn is admitted at room 46 holding area until the status is determined. Since all mothers are screened for COVID 19, those who are negative deliver at the fourth floor operating room, and the newborn is roomed in with the mother at Ward 16 or, if needed, admitted to the NICU. The other modification is institution of PPEs during delivery and subsequent care. For those newborns delivered to COVID 19 suspect or confirmed mothers, level 4 PPE is required from delivery during resuscitation until care. Whereas level 3 PPEs are provided for deliveries at the fourth floor OR. Another intervention is provision of your viral filter whenever we perform positive pressure ventilation in the setting of possible COVID 19. These viral filters are also utilized in our ventilators and CPAP machines. This ends our first lecture in the newborn resuscitation module. We will now open the floor for questions from the audience. Thank you.